for joining this evening for our Fellows Case Call. And tonight we're very fortunate. We have two presenters, Ram Narayan and Tom Shoemaker. And we're going to start with Ram first. And Ram, please feel free to begin.
Hi guys, thank you Emily and thank you Kathy for letting me participate in this Fellows Case Conference call. I appreciate the opportunity and this great learning opportunity I think for Fellows. So let me get started with my case. Okay, so let's see. Okay, so the chief complaint is acute onset confusion. One might wonder why this made it to the MS Case Conference call, and there's a few interesting aspects to this case, and that's why I'm presenting this patient in this conference. So we have a 50-year-old lady with a history of RRMS. She presented to an outside facility after she developed altered mental status and seizure-like activity in June 2016. So this all began when, 2 days before she went into the hospital, she was sitting in a chair, and then her husband came into the room, found her like she was acting confused. She was not sleeping for 2 days. She was apparently chasing away dogs outside the house when there was nothing, and so possibly had some hallucinations. And the husband also said he noticed twitches in the face, and basically she was acting confused, not recognizing family members, and was having incoherent speech. So when she went into the outside hospital, she had an initial infection workup, with the basic workup, basically cultures, urine analysis, chest X-ray, and all of that was negative. She was anyway on empiric antibiotics. She got an MRI done, which I'm going to show you in a couple of minutes. That MRI showed a linear enhancement. I'm sorry, so this was the MRI done in the outside hospital, so we don't have that MRI. So this MRI showed linear enhancement of the medial aspect of the right temporal lobe with surrounding abnormal flare signal. And so, well, because it was the temporal lobe enhancement, they worried about possibly herpes, and so acyclovir was started. CSF done by them was reported unremarkable, and a HSV PCR was negative. So after about 2 days, once this HSV PCR came back, they just continued the antibiotics, and they discontinued the acyclovir. And at that time, they had not sent the CSF for JCV PCR. She was discharged home, but then returned to the same hospital with worsening confusion, difficulty to arouse, and urinary retention. She was found to have a urinary infection and a worse appearing MRI. And basically, as far as the MRI was concerned, it was reported that it was unchanged enhancement, but the flare signal was worse. So at that point of time, she was transferred to us. On transfer, we only got the reports of the MRI. We did not get access to the CV somehow. So we had to repeat a lot of the workup. So as far as her MS history is concerned, she was diagnosed with MS in 1994, and she presented with optic neuritis, unclear which side, and she had typical CSF and radiologic findings at that time. She was treated with Avonex from 1996, and since 2006 all the way up to 2016. So for over 10 years, she's been on Tysabri. As far as her initial JCV antibody status was concerned, she was initially positive as of February 2015, and then a repeat assessment in May 2015 said that she was indeterminate, and later on she had a negative test. So the last JC test that we had, antibody test that we had, was a negative test. So her Tysabri was continued, and her last dose was 5 weeks before this clinical presentation. So probably in May, the last week was May, and last week was and her symptoms started in the end of June. On arrival, she was afebrile, her vitals were stable, she was somnolent, and she was arousable, loud voice. She had a left RAPD, she had a right INO, and she had left more than right lower motor element type of weakness in the face. I'm sorry, I didn't mention face. And she has diffuse hypertonia. Her strength was 2+ in the upper extremities, 1+ in the others. She was pretty weak, and my testing was also limited partly because of the altered mental status. But to the best of my abilities, she was less than anti-gravity in upper extremities and lower extremities. Her deep tendon reflexes were symmetrically diminished, and she had upgoing toes bilaterally. She had no abnormal movements, and I did not find any neck stiffness. When she got her initial workup, her sodium turned out to be 120s, and her CSF showed 113 white cells with 99% lymphocytes. Her glucose was 47, CSF glucose was 47, and her concurrent serum glucose was 91. Her protein was 54, and she had a normal opening pressure. HSV1 and 2, West Nile virus, CMV, Cryptococcus testing in the CSF had come back negative, and she had an extensive bacterial and a fungal workup in the blood, which was negative, and she had a TB quantiferon, which also, this was reported from the outside hospital, and that was negative. We got an EEG when she got admitted on day 1 of admission, and she was noted to have diffuse delta slowing. And then when I went and saw the patient about 2 to 3 days after she had come into the hospital, this was her workup, which was pending. So she had a JCV that was pending. She had a HHV6 PCR in the CSF that was pending, her MTD in the PCR, West Nile virus, enterovirus, varicella, histoplasma, the fungital panel in the CSF, and CSF flow cytometry and cytology. These were all pending. So let me show you the MRI. Can all of you look at the MRI? Is it clear? Or?
Yes.
It's clear.
Yeah.
Okay, good. So I have put a FLAIR image here, and I'm pointing to the image with my mouse. So I want to draw your attention to a few areas in the FLAIR. So we obviously have these abnormalities here, and we have Dawson's fingers on her sagittal FLAIR. Nothing on contrast enhanced T1 yet, but let me show you more sequences. So if you look at this image here, we can see some subtle leptomeningeal enhancement here in the parasagittal fissure on the right frontal lobe. And let me, yeah. So, and then this here, again on T1 post contrast, we can see some on the right temporal lobe. There is a there is a streak of contrast enhancement here with a corresponding FLAIR signal surrounding it, and interestingly, it looks a little flame shaped. The contrast enhancement itself looked like a splinter, so it looks a little flame shaped. Now I just wanted to show some more contrast enhancement on the leptomeninges of the cerebellum here. And so this was a radiology read. So this was our radiology read. Multiple scattered foci of enhancement within the leptomeninges involving the cerebral and the cerebellar lobes. And there was an incomplete ring. It's not right. It's a ring of non-enhancing increased T2 FLAIR hyperintensity within the superior gyrus, in a complete ring within the superior gyrus of the right temporal lobe. So this was a radiology read, and yeah, so the other demyelinating plaques due to MS were otherwise unchanged. So at this point of time, what would you guys call for differentials?
Well, I mean, I think the thought on everyone's mind is obviously PML, given her, extended use of natalizumab for over 10 years. The one wrench is that she supposedly is JC virus antibody negative, according to her most recent results.
Mm-hmm.
But she has that one prior positive reading, and so, I mean,
Right.
do we approach this as saying that, we go off of basically the most abnormal test, or if it's been positive, we treat her as positive going forward, or do we just consider it a false positive, I guess?
Well, that's a great idea, and obviously, I was worried about PML2 at the beginning. No, one interesting thing though is I have not, and please let me know if this is if you guys have think otherwise. Have you guys seen this pattern of leptomeningeal enhancement with PML?
No.
No.
Yeah, that was something which was a little atypical in this patient, and I know PML can cause, again, the other thing is altered mental status. So I was hearing more in the terms of, so PML in a textbook description should be like in presence of visual field cuts, dysarthria, some ataxia, some gait changes, but how often do we see PML with confusion? So that was, unless we say that UTI and PML and a low sodium, and so there was two processes going on.
I think, I mean, at least the few PML patients we've seen here have had some degree of alteration in mental status, but it's more subacute. This is a little bit too acute, or I mean, at least with the little experience that I have. One patient that we had subacute alteration in mental status for about a month before she presented, and was very, very subtle. Like, she was still going to work, making errors at work. This case is more acute from what I hear. It's happening very rapidly. That's a little atypical for PML.
Have any of you seen leptomeningeal stuff with PML, leptomeningeal involvement with PML?
No, I haven't seen leptomeningeal enhancement.
I mean, biologically, I guess it makes sense because it infects the oligodendrocytes, and so technically we shouldn't be seeing meningeal involvement, but okay. So anyone have any other thoughts?
One thought I had is, sorry, too many people. I think you mentioned that the natalizumab was stopped 5 weeks before presentation, so I don't know about iris, maybe can be considered. I'm not sure if the scan would be typical for that, but just something to think about.
Yeah, I think that's a great thought.
Okay, thanks.
Do you know why she was switched to natalizumab in 2006? Was she progressing, or her MRI spread looks pretty good for someone who's had MS for that long?
No, actually she had a relapse and she was admitted, and so she was basically failing Avonex, and so that's why she was switched.
Okay. Have you guys seen that degree of CSF pleocytosis with PML in the past?
Yeah, that's another good point. Yeah, that's no, I have not, and yeah, let me go back to that. Okay, yeah. So I have not. So that's another question I had. Have you guys seen, this kind of a picture, like, low glucose, and you have white cell, 113 pleocytosis. I mean, that's concerning. So yeah, let me know if others have seen this.
Yeah, I would say that's a little atypical for PML too, because PML is not really an itis because there's an absence of inflammatory cells in the CNS. So typically you don't, I mean, most of the case reports I've seen, there has not been a lot of pleocytosis in the CSF. So I'd say that's very atypical for PML.
So
something I was thinking about before I saw the MRI was maybe some sort of, and I know this is going kind of to the zebra category, but some kind of paraneoplastic syndrome, especially like anti-voltage gated potassium channel antibody syndrome with the facial twitching, because they can get that like facial grimacing type of seizure and altered mental status, although again the like really acute onset of it doesn't really make sense. Usually that's more of a subacute thing.
Well, I should tell you that as residents, I did residency in this program, and we have been. It's very hard to resist the temptation to not send paraneoplastic panels in these patients. We've been pretty much abusing these panels, but for this patient, it was not sent.
Oh.
Yeah, a lot of our patients we usually send. Okay, so that's a good thought. So, well, the differentials we had in mind were bacterial meningoencephalitis. Primarily because of the the CSF picture. Although it had a lot of lymphocytes, atypical bacterial infections like Listeria can cause more lymphocytes, even in the acute phase. Obviously, PML was definitely on our list. Now, Cryptococcus was on the differential, but the antigen, cryptococcal antigen testing was pending, and TB meningoencephalitis was definitely in our differential. VZV was in our differential. Enteroviral infections were in our differential, especially because we were seeing a lot of enteroviral infections in children right around that time. And then HHV6 also is known to cause a type of meningoencephalitis. Lymphoma was a differential that we had considered in this patient. And we obviously other non-infectious pathologies were considered, like lymphoma, cancer, and we considered a possibility of vasculitis, and certain things which were a little not consistent with Occam's razor. So maybe are these two processes going on? Is there an MS relapse with a UTI, plus or minus a toxic metabolic etiology, or maybe is Tysabri not working, or is this MS, or is this sarcoid with the leptomeningeal stuff that we were seeing? Was the diagnosis, did we get the right diagnosis wrong right from the beginning? And obviously, just as an explanation for her altered mental status, was she having status epilepticus from a toxic metabolic etiology? So these were the differentials we considered at that point in time. Yeah, I just highlighted the infectious causes, the neoplastic causes, and the demyelinating autoimmune causes. That's the vasculitis. So the JCV and the PCR came back negative, and this is and this is welcome to discussion. So I think the sensitivity of JCV PCR is not that great through all labs, and I've heard that sensitivity is up to like 80-90%, or probably even actually 60 to 70%. So do any of you guys have an idea as to how much we can just go by one JCV PCR in the CSF compared to multiple samples like we test for lymphoma?
I mean, in our facility, what we do, if there's a high suspicion, we send it through our lab, and we also send it to NIH.
Yeah,
and I can. Okay, yeah. I mean, we've always seen that the NIH titers have always been higher than the regular lab. So if you send it to NIH, that's. Yeah. I think that's the more sensitive from the little few patients we've had.
Yeah. Yeah, we sent it to NIH to Dr. Eugene Major, and he helps with that. So HHV came back negative. Tuberculosis came back negative. West Nile PCR came back negative. Enterovirus PCR came back negative, although it is noteworthy that we see a lot of kids with presumed enteroviral infections of the brain and the spinal cord and the meninges at times with negative PCRs in the CSF all the time. Histoplasma antigen in the CSF was negative. a fungi tell was done, and that was negative. Now, the fungi tell can apparently miss certain fungal infections. I don't think that's pertinent to the case, but it can apparently miss blastomyces. It can miss the spores, meaning rhizopus, mucoid, mucormycosis, aspergillus. It can miss some of these fungi, and Cryptococcus antigen also came back negative. So flow cytometry was negative, and we got a CTA to look for evidence of large or medium vessel vasculitis, which came back negative, and varicella came back positive. So our diagnosis was, VZV meningoencephalitis. Now, the case doesn't end here. It gets more interesting as we go on. So we started her on 550 milligrams of acyclovir twice a day. And do you guys think there's anything else we could do besides just the acyclovir? Would anyone do plasma exchange, or would any of you do steroids? But would anyone do plasma exchange here like we do for, Tysabri-associated PML?
I mean, I think it's an interesting point. I mean, by looking at the CSF, there's already some immune response already ongoing, so I think you'd have to weigh that with the risk of, I guess, maybe possible iris-type syndrome, but I actually don't know the right answer.
Okay. I'm just making a quick note here. Okay, so 5 days later, I got a call from the resident saying that the patient had worsened. The resident had come in that morning, examined the patient. She was minimally responsive, and her sodium was 128, and it was slowly corrected. And there was no bleed on CT brain, and we got a stat EEG. There is no evidence of status on it. And so anything else to do at this point of time? Would any of you, the MRI or the CSF?
I would repeat the MRI because you can get like a VZV vasculopathy, and it could be causing littler strokes that won't be able to be shown on a CT brain. Maybe that could be why she has altered mental status, if her blood vessels are clamping down.
Okay, so my only question though is, would that help? I guess, how would we differently treat it? If let's say there was stroke on the MRI, would we treat it any differently than just with acyclovir, or?
I don't know. I mean, I don't know what the evidence is behind, if she was having a stroke in one particular area, what intra-arterial calcium channel blockers would be helpful in that situation, or trying to boost up her blood pressure a little bit. I actually don't know the evidence behind that. I'm just postulating.
I think it would just make it a little bit more complicated, because if it's more of a vasculitis, like an inflammatory response in the vessels of the artery, then steroids may be indicated. But then the fact that she's been on Tysabri, you really want her immune system to fight this VZV. It's just a balance of, can we give her steroids if there's some kind of vasculitis or vasculopathy that's going on caused by an infection?
Okay. Okay, so so her repeat MRI was worse. We did get a repeat MRI, and we did repeat the CSF. And the CSF this time showed 49 white cells. Remember, the first time it showed like 115, 113 white cells. and it had 86% lymphocytes and 46 glucose. The protein was 122. So overall, it looked like the pleocytosis was better, but the protein count was higher. So probably lesser inflammation, but probably more, damage at this point of time. And this was the repeat MRI, and this is what I meant by, it being worse. So initially we had only one so we're looking at a contrast enhanced T1 sequence, and in the first MRI that I showed you, there was only this flame-shaped enhancement here. Now we're seeing another, and then we also see multiple here. Here in the right frontal parasagittal, and also in the right sylvian. I think this was the same. This is the same as this. So that's what we got, and then this was done 2 weeks after she had come into the hospital. By the time this was, after she had worsened. So more post-contrast T1. We see some on the left frontal area as well, and we see more contrast enhancement in the leptomeninges of the cerebellum. So radiology read this as an interval mild increased size of several of the enhancing lesions, as well as new foci of enhancement, and the previously seen flare signal in the right superior temporal gyrus had significantly improved, but and there were other areas of flare signals which persisted. So they also read this as so they also mentioned that in addition to few vessels within the right sylvian fissure and the right lateral convexity demonstrate mild peripheral enhancement, which may be related to vasculitis. I think they were pointing out to this one. Sorry. I think they were pointing out to this one where you see this, peripheral enhancement of this vessel here. So, what would be the next step? Would you guys, think about biopsying this, or could you think repeating the VZV PCR?
I think I would go with steroids at this point. Her pleocytosis is improving, so you're presuming that you're treating the VZV. She's obviously got inflammation going on. So I think I would pull the trigger on steroids.
Okay. But theoretically, steroids are supposed to worsen VZV if we don't think inflammation is a major cause. If we think that the immune system is not doing major damage and we are giving steroids, then the risks of patient worsening may be higher than mitigating inflammation with steroids. So, well, that's
either way, like if you biopsy, you're presumably looking for a vasculitis, which you would treat with steroids, and repeating a VZV PCR, whether it's positive or negative, there's no other treatment for VZV, so you're not going to escalate any treatment on the VZV because of that PCR, right? I don't think there's anything more you can do other than acyclovir.
Okay, so the biopsy was deferred because, we had considered a biopsy for looking for lymphoma, but the biopsy was deferred, and the had sent for a repeat VZV. The patient had worsened by this time, and she was intubated in the ICU. So, any thoughts at this time? So, what is likely to help her? Biopsy alone at this time, a 4-vessel angiogram. Maybe go back and check the dose of her antivirals, and check for resistance to acyclovir, and attempt to correct her sodium better, because her sodium has been consistently low all this while. And ICP monitoring and correction is needed. Or if there's any other ideas.
I mean, I think I agree with the point about trying steroids, because if it's a vasculitis, if it's an inflammatory response, which I mean, I think VZV vasculopathy is more of a vasculitis where you have inflammation around the vessels. I think a trial of steroids, I mean, in continuation with acyclovir, would be something that I would consider.
Okay.
I guess I'm personally not familiar with checking for acyclovir resistance, so I'm not quite sure what the utility would be in this situation, but I think that's kind of interesting.
I'm sorry, Tom, did you say you would check or you would not check?
I guess I'm not familiar with that test, to be honest, myself personally, so if it seems like if it's a worthwhile test, I'd be interested to see what the result would be.
This is Ellen. The only other thing I was wondering is, did you guys, you happen to, she was still on Tysabri, right, before she got sick?
I'm sorry, say that again?
Oh, sorry. So she was already on, she was on Tysabri, right, before getting sick, right? Like you didn't do a washout of any kind?
Yeah, no, she did not.
Any kind of plasma exchange or anything?
So no. So yeah, so she did not get a washout, and her last Tysabri dose was 5 weeks before her symptoms started. Her symptoms started on the 28th of June, and her last dose of Tysabri was the mid of May.
Yeah. So who knows if it would help? And but
who knows if it was still lingering around? You mean?
Well, yeah, right. So 5 weeks later, you may not be able to do too much is the point, but I don't know. I had a patient I inherited from a different clinic who had PML, and he actually survived, but I wondered if I should have done a washout. He actually never had PCR clearance or PCR evidence, so it sort of delayed the diagnosis. But I wonder in the case of VZV if there's any, if she's kind of going down the tubes, is there any like, you know, role for immune constitution? It sounds like she's really in dire straits, you know?
Okay.
I don't know. There's no right answer, right? Not enough cases.
Yeah, I'm going to ask that question at the end because I myself have the question. Anyway, so we verified the dose, and it turned out that she was grossly underdosed, and I shouldn't take credit for that because this was well, the story is interesting, and I guess we so the infectious disease attending goes by, and this is Dr. Ben Greenberg's brother, who's an infectious disease attending, and Dr. Ben Greenberg is one of the MS NMO doctors in our faculty in our division. So he calls up his brother and says, "You guys don't know to dose acyclovir? What's going on?" And then that's when we all got worked up, and we were like, "Oh my God, the dosing is wrong. The correct dosing is 10 to 15 milligrams per kilogram 3 times a day, but she was getting 550 milligrams twice a day, which was 8 milligrams per kilogram BID. So she was significantly underdosed. So we had corrected the dosing. By this time, the primary team also requested for ICP monitoring because she was in the ICU, and neurosurgery had done an ICP monitoring. ICPs were normal. She started getting better. She got extubated. She was out of the ICU in 10 days, and we had continued this dose of acyclovir for about 21 days, and then she was discharged to a skilled nursing facility. 4 months later, she came to the clinic alert and oriented, and she was conversing very well. She was in a power chair with some residual cognitive and visual symptoms, and she had a pretty good-looking MRI. So as we see here in these contrast-enhanced T1 images, we don't see any of the, so if you see in this where I'm pointing out the mouse to, there's no leptomeningeal enhancement in the cerebellum, which we had seen previously. And the enhancement that was here, the flame-shaped enhancement that was here in the right temporal lobe, had also gone away, and she also, the flag signal also went away. I think the lessons that we learned from this patient's case was Tysabri increases the risk of herpes infections by impairing CD4 and CD8 migration to the CNS, and so we're trained to think PML is the is the main cause for somebody with acute neurological impairment, acute or subacute neurological impairment when they are on Tysabri, but turns out that they had studied 20 patients, herpes infections in the CNS in patients with Tysabri, and this is the article that I pulled up for that. It's below in my PowerPoint, and 4 of these patients had VZV. So the correct dosing is 10 to 15 milligrams IV 3 times a day. So each dose has to be 10 to 15 milligrams. And we actually did mention this. Turns out that what happened after our initial recommendation was pharmacy called the primary team and said, you guys have this patient on an insane dose of this, acyclovir, and the patient already has some renal impairment, so we're not supposed to do this kind of a high dose. So, and then the primary team let pharmacy dose it, and pharmacy had dosed it at the 550 milligrams twice a day. Now, so that was a good learning point, and we had to push for a higher dose of acyclovir to protect her brain. Now, luckily, she did not. Her creatinine function remained the same, and we had hydrated her well, so we could. She did not sustain any permanent renal damage as well. So the questions for this group would be from what I was wondering was, is there a role for plasma exchange to wash out Tysabri? I know this came up just recently in this call. 4 to 5 weeks after somebody's had the Tysabri. So if you're looking at Tysabri washout, would it have left the system by then at 5 weeks, at the end of 5 weeks, or would it, is there some value to plasma exchange this patient? And then the other question is, how many of us would be comfortable with restarting Tysabri? So now that we know that there's an infection and we have treated the infection, how many of us would be comfortable restarting the Tysabri? And the other question is, would you check the varicella titers before starting Tysabri again? So these are the questions I had for the group.
I mean, for the last question, I don't know if having titers to VZV would prevent, like if it's going to happen, I don't know if you have titers, I don't know if it matters, because Tysabri blocks lymphocytes from entering your CNS. I mean, if you've been exposed, if you've had chickenpox before, you have that virus in you. So I don't know if you have positive antibodies that would translate into not getting a VZV meningoencephalitis if you are treated with Tysabri. I don't know, but it's. I feel like it's possible that you may still get it even if you have titers because you don't have immune cells in your CNS.
Mm-hmm. Got it. Any other questions or concerns as far as restarting Tysabri?
I don't think I would restart Tysabri on this patient because I feel like it's going to happen again.
So what would be your the choice of DMT for you guys for this patient? So if we have to do another DMT for this patient, I'm sure a lot of you would not do Gilenya. So if you did Gilenya, or will some of you do Gilenya this patient? And if not, what else do we do for this patient?
Maybe Rebif would be a good option, like a higher
Sorry?
dose. Maybe Rebif would be a good option, like a higher dose interferon, because she was on Avonex before, right?
Mm-hmm.
You could argue that maybe the Rebif would be a little bit more effective.
Okay.
I mean, I guess
This is a patient who had a very mild case. The same guy I was just telling you about who developed PML. This was treated for years with Tysabri, and his brain MRI showed, like, probably 5 lesions.
I'm sorry.
So, and very little disease activity.
I'm sorry.
So, after,
We can't really
so
hear
after he improved from the PML, we actually, about 2 years have gone by, and we haven't restarted any disease-modifying therapy, and he's done fine. So I basically decided I wasn't going to do anything until he proved that he was still inflammatory, and he really is fine. He's in his late 50s.
Oh, wow. Okay.
Yeah, I think with something like this happening, I mean, at least with the few PML cases I've seen, we've always done an ABCR because anything
You've done what?
like Copaxone or an interferon. Because Gilenya, Tecfidera, all of them are going to suppress your lymphocytes. Like it's just, with something like as bad as PML, you just, in the case of PML, we've always just done something very safe.
Right.
In this case, I think I would be prone to do the same thing by choosing something that's extremely safe.
Right. And even the interferons, right, can cause lymphopenia. So something to keep in mind even for those.
Yeah.
Rare, but I've seen it.
Would you vaccinate this patient after this? I mean, I don't think she needs to be vaccinated because right now she would have developed antibodies, but what if she has adequate levels of antibodies to varicella? In which case would you be comfortable restarting Tysabri or Gilenya, this patient maybe?
I think you'd want some evidence that she needs something that's strong, right? Like, I mean, I know you're just meeting her too, but there's not really a great indication from the history presented that she needs it.
I'm sorry, you're saying she may not need anything at all?
I'm not sure that I would. I mean, she almost died from a severe infection in the brain. I think you can give her some time to clear it up and declare what her MS course is like at this point, There's a, reduced risk of ongoing inflammatory activity as age increases, right? So she's had a long disease duration. She may have burned out anyways.
Okay.
And I don't think, even if
or
she's
Copaxone or
vaccinated,
something.
even if she's vaccinated, I don't think, because I think the problem with Tysabri is, I don't think it matters that you have titers, it's just that you have an absence of lymphocytes in your CNS.
Mm-hmm.
Even if you vaccinate this patient, I don't think it protects her from not getting it if you're still giving her Tysabri.
Yeah, I'm sorry, I'm just thinking a little ahead. I understand that you may not want to treat this, but what if she, in 6 months of time, let's say she comes back with a relapse. She has not yet, so she's doing good now, and we don't have any therapy as of now. But the next question is, if she comes back and if she has this question, what are you going to do for me if given my disease in the past and my failure on Avonex, what would you do for me if I had another relapse or to prevent me from having another relapse? So that's where it gets really challenging, I guess.
I mean, honestly, I think I would start Rebif. I would agree with Veronica and start Rebif. If she breaks through on Rebif, then it's another conversation of, what else can we do? But at this point, I think doing a safe option, because we're just doing more, I feel there's more harm we're doing by giving her something that's going to suppress her lymphocytes. I think just doing one of the basic, like Rebif is a higher dose than Avonex. And if she breaks through on Rebif, then have another conversation about should we do something stronger. Because an MS relapse, I think, is far better than getting, VZV in your brain.
This is Ellen. I totally agree. I think it would be actually a harder thing if she was, within 5 years of onset. But, I think that the likelihood is that her disease is likely to have burned out more at this age, and also, there's debate about what the impact of, later in the stage relapses is compared to early relapse and how much that contributes to long-term prognosis. So I would rather take the risk of a relapse if this were my patient than and either wait or start something mild, right? The other thing to point out is that, even with injectables, there's these reductions in relapse risk are all relative, right? So higher efficacy, as it were, wink, wink, injectable may be perfectly reasonable.
So, Dr. Murray, we have the patient on no DMT now because we were also very nervous to start anything. So, I think we'll have to wait for her herself to declare as to what her immune system is doing.
Yeah, and like I said, for my guy who was on Tysabri for like 8 years, nothing, not one lesion, not one attack since he stopped the Tysabri. And I have some input from my 2-year-old. Sorry. That's a very nice sentence.
Well, thanks a lot. If others don't have questions, I'd like to thank my mentor, Dr. Elliot Froman, Dr. Benjamin Greenberg, who was involved in the case, and then Dr. Okuda, who was, the MS doctor for this patient, and who helped me up with this case as well. Sorry for a lot of time.
Great case.
That's a great case.
Thanks. That was a great, I agree, and good discussion. We also have Tom Shoemaker, who is going to present a short case, and I just want to know from you, Tom, it's 6:52 Eastern time. Will this be enough time for you?
Sure, I can get through this quickly. I mean,
Okay.
it's pretty straightforward.
Which video do you want me to show? The 29-second one?
The 29-second one is the one that, if we can get it to work, is probably the most interesting one.
Okay, I'm ready whenever you say go.
Okay. Would you want me to go ahead and start with the case, and then we can watch the video?
Sure.
Yeah.
Okay. Now, do you want to switch over to my screen?
Okay, you got it?
All right. And are you seeing the presenter screen or the actual presentation?
We're seeing the wrong side.
Okay. I can fix that. How's that? Better?
Perfect. Yep.
Yeah.
Okay. So this is a very short case. I'll keep it as short as I can. I presented last month, but I want to present again because this patient actually asked me to show his video to as many doctors as I can find. So I felt I could do him the favor and kind of share his case with you guys because it's still an open-ended case, and I'm kind of looking for some additional recommendations for, I guess, additional testing in his case. So this is a 74-year-old retired computer engineer who came up to us from Florida, and he's been neurologically healthy his whole life and actually very active, so active that he's an avid tennis player. And in mid-August, he noted that he played in a tennis tournament. It was about a 3-hour tournament. He said it was particularly hot outside. The tournament ran out of water, and he played the last hour to 2 hours of the tournament actually with not drinking any fluids. He still was able to perform well enough to come in second place, and he otherwise felt fine after the tournament. He didn't kind of do any aggressive rehydration afterwards. He didn't eat any salty meals or anything afterwards. But he's very concerned that possibly kind of going through this strenuous tournament maybe led to some of his symptoms because it was about 3 or 5 days after the tournament. He's not quite sure. He began having episodes of abnormal symptoms. And what he describes is he would have basically no aura or prodrome prior to these episodes, other than a wave of dizziness. And the dizziness he really described as more of a wooziness or swimming sensation, not frank vertigo. He said the best way to describe it was like a very bad hangover that only lasted several seconds. And then this would be followed by pretty profound speech difficulty, and I'll show you a video of that in a second, where he has an inability to produce fluent speech. His words are slurred, and he feels like his tongue is being pulled down into his mouth. But but
Wow.
no vertiginous-like symptoms, and otherwise no bulbar symptoms outside the speech difficulty. He can understand others, no alteration of consciousness. And each of these episodes lasts between 10 and 30 seconds, and they can occur at varying frequencies, either 5 to 30 times each day. Now, he has had a couple of occurrences while he has these spells. He actually has noticed that his gait has changed too. And he'll feel like he's being pulled to one side or he has some veering. However, he's been able to kind of quickly stabilize himself, stop walking, and so he hasn't had any falls. But this has only occurred concurrently with speech difficulty. In between these episodes, though, he's entirely neurologically healthy and otherwise feels quite well. And so, any clarifying questions so far?
With the inability to produce fluent speech, is it because of the dysarthria, or does he have dysarthria and aphasia?
No, so it's purely dysarthria. He says he can think of the words he wants to say, and he can understand those around him, but he just feels like his tongue is not obeying what he wants it to. And he feels like if he's trying to talk long enough, the words will just slowly come out as these symptoms resolve.
Okay.
That's an excellent
Any
question.
headaches with this, Tom?
No headaches, no. Excellent question. We asked him that as well, too. And there was no clear precipitants. They would happen, in his impression, they were entirely spontaneous. And they didn't seem to occur at one point in the day versus another point in the day. They weren't very fatigable or brought on by any type of stimulus. In his mind, they were entirely spontaneous.
Mm-hmm.
And so from September started in September, and between then and December, his spells basically remained unchanged. They kind of just persisted. He had kind of withdrawn from tennis and some other activities because he was worried he would fall if he remained engaged. And so it got to a point that he presented to his physician, who actually sent him to the emergency room because he was concerned that he may be having a stroke. And he underwent pretty extensive kind of neurovascular evaluation initially, which showed some abnormalities on the brain MRI, which I'll show you below. And so he was actually given a brief course of steroids, prednisone, about 60 milligrams per week, because of the MRI findings. But that didn't really change his symptoms. And then they trialed him on Mestinon, thinking perhaps this is an atypical form of myasthenia gravis, and that didn't really have any improvement in his symptoms. Some notable past medical history: he had papillary thyroid cancer, for which he had surgical resection in 2010. He had dysplastic nevus when he was younger, which has since resolved. He's been on Synthroid. He's a retired software engineer. He otherwise lives a healthy and productive life. So I guess if we could look at the video now, that'd be nice. Okay.
Type 2, ataxia and dysarthria, presents in an older person and responds to diuretics, interestingly.
Okay. So zebras are entertained during this presentation because we're still trying to figure
Yeah.
this
I've never seen it, but it sounds kind of like the description I've read of this.
out. Okay.
Well, another thing, Tom, is based on the symptoms that you described, I think it comes on pretty acutely, and there's very few neurological things that can come on acutely. One is vascular, which doesn't sound like this, and then the other one is electrical phenomenon, which either could be migrainous phenomenon, or some sort of electrical phenomenon involving the brainstem and the trigeminal system, maybe. And obviously, I mean, even if these are seizures, it's hard to. These could be seizures, and we may miss it on a scalp EEG. So. Right. These are the thoughts I had. Have you tried empirical, like Tegretol or something?
So we'll get to that point soon enough, but I'm enjoying your train of thought in some ways.
Okay.
So I guess for the sake of time, I'll just kind of keep things moving. So is the right screen up, or do they switch again?
They switch.
Can you see my?
They switch presenter, yeah.
All right. So here we are. So his exam was normal, except for he had a number of these episodes. He had about, in the course of about an hour examination, he had about 6 of them. But during them, he retained consciousness. He was able to follow commands, and he basically continued his conversation and his train of thought. His language was transiently altered. And so the outside evaluation had taken place, and they considered myasthenia as well as some kind of basic rheumatologic conditions, all of which was normal. They did do a lumbar puncture, and I don't have the results yet of it, but reportedly everything was normal, with the exceptions they did not send any kind of intrathecal immune process labs, so no oligoclonal bands or IgG index were sent. But there was no pleocytosis, protein and glucose were normal, and of the other, they sent a meningoencephalitis panel, which is also reportedly normal. But so here's his MRI, and so he's had 2 MRIs, both were obtained within a month of each other. So this is from 9/22, and when you kind of walk down, he has some non-specific, subcortical white matter changes. He has a little, I think maybe a little bit of, ventriculomegaly. It seems like they're slightly large, and there's some kind of T2 signal change around it. But then when you come further into the brainstem and specifically the kind of midbrain, you'll start seeing some more signal change, including here in the midbrain. There's a pretty large area of T2 signal change that is pretty symmetric, actually, kind of in the perimedian midbrain area, and maybe a little bit of the kind of rostral pons. And this is the contrast enhanced image, and you can see there's, sorry about the lines, I couldn't get rid of them, but there's a kind of focal patchy area of contrast enhancement, which you can see a little bit better on the sagittal GAD enhanced sequence. And this also has restricted diffusion as well, too. Now, he had another MRI repeated a month later, and basically there was no change. The lesion was persistent, and the enhancement was persistent as well, too. So we had our radiologist do a second look of it, and they basically were concerned about potential neoplasm, maybe low-grade glioma, given the lack of changes, but they also were considering an inflammatory process. So, our differential diagnosis kind of going into this was maybe kind of an isolated solitary area of demyelination, maybe a neuroinflammatory connective tissue disease such as Behçet's as an example, lymphoma, low-grade glioma, potentially osmotic demyelination given his history, although it seems a little atypical, or maybe perineoplastic or metastatic disease, which is a little bit lower on the differential given his history of the thyroid carcinoma. Now, in my kind of research, what I found was a number of case reports describing kind of paroxysmal dysarthria associated with these midbrain lesions that kind of fit his case symptomatically, either paroxysmal dysarthria or paroxysmal dysarthria ataxia. But almost all of them describe some type of demyelinating syndrome. And so I just wanted to kind of share with the group whether they think this lesion could be demyelinating just in its appearance, or if they've kind of come across it in any of this type of syndrome in other contexts. So I guess, like, for example, the episodic ataxia is something that we were not initially considering. So does anybody else have anything for the differential, either on the syndrome or, yeah?
What did the cord look like?
Cord has not been imaged yet, so we just met him last week, actually, so we're still working on things. You think it's worthwhile to image the cord?
Well, the reason I was asking that was, if we have concomitant lesions in the cord, maybe you may be inclined to think this is more demyelinating than, maybe.
That's an excellent point, and that's something we think.
Usually people get symptomatic if there's even a small cord lesion, but we have seen, I'm sure, we all have seen patients with, very subtle cord without any,
Right, exactly. I mean, what would you guys do? So he hasn't had, oligoclonal bands or IgG index. Would you consider it worthwhile? Would you retap this guy just to check for those? And while you're in there, would you send any other testing?
I guess if you're thinking lymphomas on the differential, you probably need to do another high volume tap anyways if the first one's negative. So you could send the bands and the IgG index at that point.
Mm-hmm.
And doesn't look like this is clippers, right? Because
Right, yeah, so you can go back up to kind of look at it.
it was all in the midbrain, right? Oh yeah, it was all in the midbrain. Okay.
Yeah. So in a month apart, it was in that
steroids.
I'm sorry, what's that?
You said nothing happened with steroids, right? You gave him a...
So he got low-dose steroids. It was just prednisone. But it was in the month interval between the first and second MRI. So, and it didn't have any effect on it.
Okay. I mean, definitely demyelinating is possible with this ootoughing that he could be having with... You know.
Right, this kind of episodic, almost aphaptic type phenomenon.
Yeah, yeah.
Okay, well then we... Sure.
One other thing I might get is a paraneoplastic panel, because it's possible it could be a paraneoplastic syndrome.
Sure.
I mean, the anti-PCA, I think that is more cerebellar, but there may be something, you know, paraneoplastic that could do something like this.
Sure. Yeah, that was something we were considering.
Restriction is what makes it really, really interesting.
What's that?
I think the diffusion restriction makes it really interesting.
Yeah, it's an interesting case, and that's been persistent between the two studies.
Yeah.
Now, would you consider trying empiric high-dose steroids to see whether he improves?
After you tap him, because if it's lymphoma, you're not going to get a very, you're going to lose whatever,
Is
you know, the sensitivity of the test, Yeah, but I would consider steroids, but after tapping him.
Right. Okay. Yeah, I mean, so it's atypical. I mean, most of the literature that I've come across describes as episodic dysarthria in the context of brainstem lesions, but almost all of them seem to invoke some type of neuroinflammatory process. But he's a 74-year-old, otherwise healthy guy, so it just seems kind of atypical to me. I don't know what your guys' experiences with these older adults.
Sarcoid a possibility?
I'm sure it is. He doesn't really have any. I mean, he's Caucasian. He has no other kind of sarcoid-like symptoms. I don't think we have any chest imaging on him. They checked ACE from the serum and the CSF, and that was normal, but that's not obviously the best test.
What's really interesting about that lesion, it's so symmetric.
Right, exactly.
It like looks like CPM, but in the wrong area, and the story's not right.
Right, exactly. It's not the best.
That's where you were leading us with the water and the stuff in the beginning. So.
Part of his issue is that since he had the tennis tournament, his wife has just been yelling at him. It was the tennis tournament. You can't play tennis anymore.
Oh.
So he wants to get better so he can play tennis again. So, you know, I feel for the gentleman. He wants to get out there. So the reports I found describes carbamazepine as having pretty reliable response. He's reluctant to try it, though, because he read the package in here, and that describes some dizziness. So he's going to hold off until we repeat kind of the rest of our testing before trying carbamazepine.
Well, I
Which
think
underlying pathology does that help for?
I'm sorry, what's that?
Which diagnosis does that help for?
So some of the cases from all the MS and I think some of the other kind of inflammatory demyelinating lesions, I mean, some of the articles basically say it's pathognomonic syndrome in MS. I know it was a German article from 1974, but you know, it seems like it's something that we may come across in other MS-related patients because most literature seems that this is primarily something we see in multiple sclerosis, but other pathologies have been recognized since 1974 as a cause of this. But I think, you know, all of us at some point in time may come across this syndrome, and someone we know has MS at the very least.
I think.
Sorry.
No, go ahead.
I just was saying that I mean, he doesn't have anything else in the rest of his brain that looks like he doesn't have periventricular lesions, doesn't have callosal lesions.
Yeah.
I mean, based on his age, malignancy is kind of high. Either paraneoplastic or malignancy is high on my differential.
Okay.
So I would definitely get a second tap, and I would like paraneoplastic panel, and also consider like a malignancy screen, like a PET scan or, you know, CT chest, CT abdomen and pelvis.
So I have two comments. One is, I think irrespective of the primary etiology, Tegretol might help because demyelinating or tumor or vascular or CPM, whatever is happening to him seems to be like an electric phenomenon.
That
is number one. And then the other thing is, I'm sure you guys sent an NMO, right?
So we had it, and I was thinking about that, and that's, you know, he's kind of older and he's got some atypical symptoms. So you think that we should send it?
Yeah, the age is atypical. And the only thing is, it's brainstem, and it's there's like the subtle white matter stuff in the cerebral hemispheres as well.
Yeah.
No.
No, I agree. I mean, I think, you know, you guys kind of supported some of the thoughts we had going along with this, but I think it's helpful to kind of bounce these ideas off you guys and see if you know, there's anything we're missing, and I think it's been helpful.
We'd really appreciate if you can, you know, tell us the final diagnosis once you guys make it.
Once we figure it out, I'll let you guys know, and I'll probably get some videos of him when he's on Tegretol to prove that it works.
And Tom, if he has trouble with Tegretol, which, you know, sometimes can cause a lot of other symptomatology, a lot of ataxia and unsteadiness, sometimes for paroxysmal symptoms, a gabapentin might actually work as well.
Yeah, that's what I was thinking. Actually, I came across one report that I think described lacosamide being used as well for this condition. So I figured carbamazepine seemed like it was probably going to be tried and true, so we'll see how he does.
Right.
Okay, well, I want to thank you guys. We went over a little bit, but it was worthwhile.
Thanks. Thanks, Tom. This was an excellent call. Good case. This is a little bit of a cliffhanger because we want the follow-up on this. So on one of our subsequent calls, please jump in and let us know what's going on. So thanks, everybody, for hanging in there and staying late. This was great discussion. I truly appreciate it. Thanks, Ellen, for being on the call. And I look forward to hearing from everyone next month. Thanks. Good night.
Thank you.
Thank you.